everyone. Now, finally, this is our final session, neuroendocrine tumors. And I really don't need to present my dear friend and colleague, Professor Mohammed Yassin. And he's going to be giving a Novartis sponsored lecture, as I just mentioned. And it has quite a provocative title of The Need for MDT in the Diagnosis, Detection, and Treatment of Neuroendocrine Tumors. Please go ahead, Professor Mohammed Yassin.
Thank you, Professor Maya Izzeddin, my dear colleague. Thank you, Novartis, for inviting me for this session. Our topic today will highlight on the importance of MDT in neuroendocrine tumor and why there is a high unmet need for working together with all specialties. As we all know, if physicians know from medical school, when you hear hoofbeats, you think it's horses, but sometimes it is a zebra, the rare diagnosis. Neuroendocrine tumors, neoplasm, arise from cells of the endocrine, hormonal, and nervous system, share common features, similar microscopic features, having special secretory granules, and often producing biogenic amines and polypeptide hormones, arise from various neuroendocrine cells whose normal function is to serve at the neuroendocrine interface. Neuroendocrine cells present not only in endocrine glands throughout the body that produce hormones, but also diffusely in all body tissue. Neuroendocrine tumors show amine precursor L-DOPA and 5-hydroxytryptophan uptake and decarboxylation to produce biogenic amines such as catecholamines and serotonin. Neuroendocrine tumors are not so rare. Neuroendocrine accounts for a higher prevalence than stomach and pancreatic cancer combined. Rising challenge incidence of neuroendocrine is growing faster than any other neoplasia, 6.4-fold from 1973 to 2012 in USA. There is a challenge for therapeutic intervention. Classic treatments are progressively replaced by new drugs and targeted biotherapy. Clinical heterogeneity of neuroendocrine is that they have a wide spectrum of characteristics and may differ by differentiation based on WHO classification, range of aggressiveness and behavior, sporadic versus familiar syndrome, biochemical, active functional or versus inactive non-functional, symptomatic and asymptomatic. Differentiation versus grade. Differentiation equals tumor cells resemblance to normal cells of the same tissue type, well-differentiated, moderate differentiated, poorly differentiated. Grade equals to cytologic activity in tumor cells, and the percentage of tumor cells that are dividing correlates with inherent biological aggressiveness, commonly measured by mitotic count and Ki-67 index. Low-grade malignant, high-grade malignant, low-grade, intermediate grade, high-grade, grade 1 to 2 and 3. Grade and differentiation are independent classification criteria. Grade 3 and polydifferentiated neuroendocrine tumors are not synonymous. Well-differentiated tumors may be also grade 3. Some general principles of neuroendocrine neoplasia classification. Well-differentiated neuroendocrine tumors are of variable grade of malignancy and could be stratified according to their histology grade in groups of prognostic significance. Polydifferentiated neuroendocrine carcinoma always are of high grade of malignancy and could be distinguished into two subtypes according to tumor cell morphology. Neuroendocrine neoplasia might be associated with non-neuroendocrine components to form mixed tumors. WHO classification of digestive neuroendocrine neoplasm 2010. This is very important. Net G1 is well differentiated, less than 2 mitosis, and Ki-67 index is less or equal to 2%, and grade of malignancy is low. Net G2 is well differentiated, 2 to 20 mitosis, and 3% to 20% Ki-67 index. And this is of intermediate grade of malignancy. But large cell neuroendocrine carcinoma and small cell neuroendocrine carcinoma polydifferentiated, more than 20 mitosis, and Ki-67 is more than 20% with high grade malignancy. In the WHO classification of pancreatic neuroendocrine neoplasia 2017, net G1 is well differentiated, less than 2 mitosis. Here, the Ki-67 is less than 3%, and is changed, and is of low-grade malignancy. And then we have net G2, well differentiated, 2 to 20 mitosis, 3% to 20% Ki-67, intermediate malignancy. Net, remember, net grade 3, well differentiated, more than 20 mitosis, and more than 20% Ki-67. Remember, still we are talking about neuroendocrine tumors. Here, we are jumping to large cell neuroendocrine carcinoma and small cell neuroendocrine carcinoma, which is polydifferentiated and has more than 20 mitosis, equal like the net well differentiated grade 3, and equal Ki-67 is more than 20. But remember, well-differentiated net G3 is different in behavior than large cell neuroendocrine carcinoma and small cell neuroendocrine carcinoma, although they have the same mitotic index and the same Ki-67 index. And the WHO classification, digestive neuroendocrine 2019, net G1 well-differentiated, less than 2 mitosis, less than 3% Ki-67, low. Net G2 well-differentiated, 2 to 20 mitosis, 3% to 20% Ki-67, and intermediate malignancy. Net grade 3 well-differentiated, again, more than 20 mitosis and more than 20%. Large cell neuroendocrine carcinoma, small cell neuroendocrine carcinoma, full differentiated, the same, more than 20 mitosis, the same, more than 20 Ki-67, but the grade of malignancy is high to very high. Pancreatic neuroendocrine, WHO 2017 versus digestive neuroendocrine, WHO 2019, net G1 well-differentiated morphology, mitotic index less than 2 and Ki-67 index less than 3%, low grade. Net G2 well-differentiated, mitotic index 2 to 20, or Ki-67 3% to 20%, intermediate grade. But net G3 well-differentiated morphology, mitotic index more than 20, or Ki-67 index more than 20%, and high grade. Neuroendocrine carcinoma, not formally graded, high grade by definition, 2 subtypes, large cell and small cell. A new cutoff between net G1 and G2, no change in mitotic index cutoff, change in Ki-67 index cutoff from less than 2% to less than 3%, to take into account changes in analytic counting methods and post-analytic expression of the results. A new frame for mixed tumor. This is a new and important subtype, change from manic mixed adenoneuroendocrine carcinoma to menin, mixed neuroendocrine, non-neuroendocrine neoplasm, to take into account the diversity of mixed tumors, non-neuroendocrine, benign or malignant, glandular or exocrine or squamous, neuroendocrine tumor or neuroendocrine carcinoma, small or large cell. A differential diagnosis between pan net grade 3 and pan neuroendocrine carcinoma grade C. As regarding immunohistochemistry, net grade 3, P53 is negative and retinoblastoma is retained. But in net neuroendocrine carcinoma grade 3, P53 is positive, around 75%, and retinoblastoma is lost in around 50%. High Ki-67 is not the same as high grade. As we have explained before, we can have a well-differentiated grade 3 tumor with mitosis over 20 versus a neuroendocrine carcinoma, which is high grade with the same mitotic index over 20%. But they are different in the behavior. Biomarkers in neuroendocrine tumors, we have chromogranin A is the best available biomarker for diagnosis of neuroendocrine tumors. Elevated chromogranin may correlate with tumor progression. Chromogranin A is elevated in 70 to 80% of cases. NSE is also expressed in neuroendocrine tumors, not as commonly used as chromogranin A, also elevated in pancreatic neuroendocrine tumors and polydifferentiated neuroendocrine carcinoma. 5-hydroxyindole acetic reflects serotonin secretion. Elevated serotonin levels over time lead to comorbidities such as cardiac disease. Other biomarkers are available, however, few have achieved widespread acceptance. New biomarkers in neuroendocrine are needed to provide better diagnosis and prognostic information. Predictive value of biomarker, progression-free survival by early chromogranin and not neuron-specific enurease response. As we have seen from RADIANT-1 trial, the median progression-free survival, if there is early response, is 13.3 months, and no early response is 7.5 for chromogranin A. And in median, as regarding NSE, median progression-free survival early response 8.6 months versus 2.9 for no response. The importance of MDT is that we have many causes of chromogranin A elevation, and we have to differentiate between this differential diagnosis. We have endocrine disease can increase chromogranin A, non-GI cancer, cardiovascular disease, renal disorders, inflammatory disorders, and many drugs can increase chromogranin A. So not only neuroendocrine tumors have an increase in chromogranin A. Diagnosis is very important. Whole body screening and staging, octreoscan, indium 111, DETBA, and octreotide, SPECT, first choice, endoscopic ultrasound, ultrasound of the liver, MRI, and CT. And what is very important now and very specific is the gallium-68 DutaToc PET-CT, which can differentiate many tumors, especially in the liver, which can be missed by other imaging modalities. A net embryological classification, net were historically classified as foregut, midgut, or hindgut. Foregut tumors develop in the respiratory tract, thymus, stomach, duodenum, and pancreas. Midgut tumors develop in the small bowel, appendix, and ascending colon. Hindgut tumors develop in the transverse colon and descending colon or rectum. The symptomatic burden of NET, the problem that we have vague symptoms, and many patients have vague symptoms and passing many years, from 2 to 5 years, until diagnosed as neuroendocrine tumors. So the symptoms of sweating, flushing, diarrhea, intermittent abdominal pain, hypoglycemia, confusion, bronchoconstriction, dyspepsia, GI bleeding, and cardiac disease can be present also in functional bowel disease, irritable bowel syndrome, alcoholism, peptic ulcer, anxiety, cytotoxicosis, asthma, neurosis, and food allergy, and menopause. And that's the important issue, why we need an MDT to work together for better diagnosis. As we see here, the core neuroendocrine tumor MDT constitutes of oncology, gastroenterology, endoscopy, surgery, and GI, specialized in endo and liver and pancreas, nuclear medicine, palliative care, pathology, radiology, and CNS. But we have to extend the neuroendocrine MDT to have also cardiologists, radiotherapists, genetics, respiratory, cardiothoracic surgery, pain control, transplant surgery, biochemistry, and nutrition. Multidisciplinary approach. MRCS offers patients optimal care through access to specialist skills. The multidisciplinary approach, highly experienced physicians specializing in the types of cancer, skilled support staff create a multidisciplinary center of cancer specialists. Expert staff work together to examine all diagnostic and treatment options for each specific case. This MDT approach ensures each patient receives the most effective individual care available. And as we see here, multidisciplinary centers are associated with improved survival for patients with neuroendocrine tumors. Median survival of patients with metastatic neuroendocrine tumors treated at centers of excellence is more or equal to 3 times higher than median survival of patients with NETs in the SEER database. Data are consistent between centers of excellence. And as we see here, this is a very important issue. I want to highlight that around 54% of patients have vague symptoms for 2 years before diagnosis, and 34% of patients have vague symptoms for 5 years before diagnosis of neuroendocrine tumors. So, as we see here, primary tumor growth, and then metastasis, and then the symptoms of flushing if we have carcinoid tumor, and which happens in midgut tumors, which with massive liver metastasis, and then diarrhea due to serotonin release. And this is the end stage, and this can lead to death. This process takes from 5 to 7 years. Sorry. Metabolic complication of neuroendocrine neoplasia, cancer-related, neuroendocrine primary tumor-related, neuroendocrine neoplasia disease syndrome-related, therapy-related, hypersecretion of hormones, malabsorption, deficiency, food intolerance, malnutrition, cancer-related complication of neuroendocrine neoplasia, fatigue, loss of energy, weight loss, loss of appetite, metastasis-related. So we need to work together in the form of MDT. What are the therapeutic options for advanced, well-differentiated neuroendocrine tumors? We have surgery, curative debulking transplantation, locoregional radiofrequency ablation, embolization, chemobilization, systemic therapy, somatostatin analogs, chemotherapy for grade 3 tumors, targeted molecular therapy for grade C tumors, and for functioning tumors who express somatostatin receptors, we have a new option with peptide radiation receptor therapy, which is highly effective in functioning carcinoid tumors. Treatment option for advanced neuroendocrine tumors, we have again somatostatin analogs, peptide receptor radiation therapy, but still not approved, everolimus, sunitinib, and CAPTEM, which is capecitabine plus temozolomide, which is a very active chemotherapy regimen. And for tumors Ki67, 10 to 20% PRT, everolimus, sunitinib, CAPTEM, and for 20% to 50% the Ki67, PRT, and targeted chemotherapy, and CAPTEM and FOLFOX. And for high-grade Ki67, more than 55%, as we all know, the historical cisplatin plus Pepsid, plus or minus irinotecan. Octreotide have a direct anti-tumor effect via somatostatin receptor 2 and 5. This is very important. Our first study with octreotide LAR was a PROMETHEUS study in which patients were randomized, in which we had well-differentiated mid-gut neuroendocrine tumors, randomized octreotide LAR 30 milligram versus placebo. And as we see here, the median progression-free survival was time to tumor progression was 14.3 months versus placebo 6 months. And for non-functioning tumor, it was 28.8 versus 5.9. And if a functioning carcinoid tumor, it was 14 months versus 5.4. As we all know, chemotherapy is not active in grade 1 and grade 2 tumor of the midgut or carcinoid tumors, but only active in grade 3 well-differentiated tumor with regimens like cisplatin etoposide, carboplatin etoposide, plus or minus vincristine. And a very potent chemotherapy regimen for neuroendocrine grade 3 tumors and neuroendocrine carcinoma is the CAP-10 regimen, which constitutes of capecitabine 700 milligram per meter square twice daily from day 1 to 14, and temozolomide 200 milligram per meter square once daily from day 10 to 14. And the study was capecitabine temozolomide versus temozolomide alone. And in this, as we see here from this waterfall plot, there is 70% partial response, which is very high in those aggressive type of tumors. And by the way, the median overall survival was not reached till now. And other regimen of treatment is a combination of mTOR plus long-acting octreotide. Around 50% of patients with pancreatic neuroendocrine tumor have mutation in the mTOR pathway. So it is rationale or a proof of concept to combine everolimus either alone or to combine with octreotide LAR. And we have 4 trials. Radiant 1 is a phase 2 trial, and we'll not talk about it. We have the Radiant 2 trial in non-pancreatic or functioning pancreatic neuroendocrine tumors in which patients have received octreotide LAR plus everolimus versus octreotide LAR, and crossover was allowed. And the result was, unfortunately, this trial was a negative trial, 16.4 months versus 11.3, which denotes that everolimus doesn't work in low-grade tumors or mid-gut tumors or functioning tumor. And the only indication for which everolimus was approved was in pancreatic neuroendocrine tumor. Phase 3 Radiant trial, pancreatic neuroendocrine tumor, 11 months versus 4.6. And in Radiant 4, GI and lung neuroendocrine tumors, non-functioning, non-mid-gut, non-pancreatic, everolimus versus placebo with no crossover. And the result was 11 months versus 3.9 months, which means that real-world data of everolimus in pancreatic neuroendocrine tumor for which everolimus has got approval is around 11 months progression-free survival. This is the design of Radiant 2, as I told you before, and this is the design of Radiant 3, and this is the design of Radiant 4 with no crossover, everolimus versus placebo. Another trial in pancreatic neuroendocrine tumor which was approved at the same time as everolimus for pancreatic neuroendocrine tumor, sunitinib versus placebo in advanced pancreatic neuroendocrine tumor. Patients were randomized to sunitinib 37.5 milligram daily continuous dose versus placebo, and the progression-free survival was 11.4 months versus 5.5. So now in pancreatic neuroendocrine tumor, we have everolimus and we have sunitinib and other treatment options on progression. But the standard of care is everolimus and sunitinib. So our very important modality is PRT, peptide radiotherapy in neuroendocrine tumor, which was approved in advanced and progressive neuroendocrine functional neuroendocrine tumor. And the most important point is that this tumor must express somatostatin receptor. So main goal of PRT is symptom relief, slow tumor progression, and improve overall survival. PRT can be used in gastroenteropancreatic neuroendocrine tumor, carcinoid tumor, small cell carcinoma of lung, islet cell carcinoma of pancreas, pheochromocytoma, radioiodine refractory thyroid carcinoma. Eligibility criteria, as I told you before, according to hematological and non-hematological lab features. Absolute contraindication is pregnancy or ongoing lactation, severe hepatic impairment, New York heart classification 3 or 4 cardiac impairment. And the PRT cycle is very important. We use an anti-emetic dancetrone 3 milligram or dancetrone 8 milligram with an amino acid infusion, lysine and arginine, to prevent nephrotoxicity, plus lutetium 177 lutetate or yttrium 90 lutetate. Treatment cycles, the cycle according to the Netter study with lutetium 177 is one cycle every 8 weeks for 4 cycles. And we can repeat the cycle if we have an initial response and the patients remain stable for at least 18 months. So if progression after the first 4 cycles of PRT happens after 18 months, we can repeat if there is initial response. Adverse events, acute nausea, vomiting, metabolic acidosis, subacute, temporary hair loss, deterioration of liver function, no great transient myelosuppression, liver toxicity, delayed 2 to 3 years or more, MDS and AML. Other adverse effects, generally mild and reversible, nephrotoxicity, subacute hematotoxicity, hematologic malignancy, reduction in spleen volume, transient damage to sensory cells and inhibitory effect on spermatogenesis, gonadotrophin decrease in postmenopausal women, and rarely carcinoid crisis, hormonal crisis around 1%. The response, as we see, as regarding complete response and partial response is high, 44% for lutetium, and yttrium 90 is 7 to 37, and tumor stabilization 35% versus 42 and 80 to 86. So as we see here in the past 10 years, we have a renaissance or a progress in the land of neuroendocrine tumors with many treatment modalities. And as we see here, the algorithm, first we start with surgery, and it is a curative intent if there is a residual tumor, if non-progressive, observation only, symptomatic trial of somatostatin analog or new drug trial. Progressive disease, consider small volume and graded tumor, interferon or somatostatin analog may be considered. Poorly differentiated tumor, chemotherapy regimen, cisplatin, CAP-10 regimen. Hepatic disease predominant, consider chemobilization third, surgery for oligometastatic disease, ablative therapy. And for moderately differentiated foregut tumor, non-midgut or hindgut or pancreatic tumors, we have the option of triptazone chemotherapy regimen or CAP-10 regimen or sunitinib or everolimus. This is the same treatment algorithm. And here I will end with some unmet needs and open question in pathology. G2 heterogeneity, neuroendocrine tumor grade 2, well-differentiated morphology, mitotic index is 2 to 20, and Ki67 index is 3% to 20%, while low grade 2 versus high grade 2, which cutoff? 10% or 15%. Same molecular features, same prognosis, and same treatment. Heterogeneity and progression in well-differentiated neuroendocrine tumors, levels of heterogeneity, morphological heterogeneity, proliferation, functional heterogeneity, patterns of heterogeneity intratumoral, intertumoral, between the primary and its metastasis, between metastases themselves, pattern and rates of progression from grade 1 to grade 2, grade 1 to grade 3, grade 2 to grade 3, from a well to poorly differentiated morphology, re-evaluation of large cell neuroendocrine carcinoma. This is very important. Evidence of molecular heterogeneity, true neuroendocrine tumor versus adenocarcinoma with neuroendocrine differentiation, clinical and therapeutic consequences, progression for well-differentiated tumors, validation of emerging biomarkers and identification of new ones, diagnosis, improving sensitivity and specificity of the demonstration of the neuroendocrine phenotype, especially in poorly differentiated tumors, identifying tissue-specific markers, prognosis, prediction of the response to treatment, validation of emerging candidates, for example, MGMT, and when we use temozolomide, retinoblastoma for platinum salt, and identification of new biomarkers. Open questions in net biology. Net biology remains poorly understood till now. Net biology is very different from carcinoma biology. An open mind is required to study net biology. The proliferative net paradox, this is very important. How do neuroendocrine manage to reach such large tumor mass despite the low or very low proliferative capacities? And the possible explanation is they are programmed for long lifespan and they have the ability for immune escape. For example, in carcinoid tumors, which originate from midgut tumors, they become symptomatic when they have massive liver metastasis. How such a low-grade midgut tumor can reach and have such high metastatic potentiality? Is it immune escape? Has the neuroendocrine tumors the ability for programmed for long lifespan? The secretory and metabolic neuroendocrine paradox. What are the biological effects of their large and diverse secretome? How do the functional specialization associated with the secretory capacity impact on tumor biology? And the invasive neuroendocrine paradox. Neuroendocrines are highly invasive and metastatic tumors despite their low proliferative capacities and highly differentiated features. What are the cellular and molecular mechanisms involved? A better understanding of neuroendocrine biology is necessary for identifying new diagnostic and prognostic tools as well as new therapeutic strategies. So at the end, we need to work together. Patients become undiagnosed for 2 to 5 years before neuroendocrine tumor diagnosed. And they, on average, they visit around from 13 to 15 different types of doctors to explain their vague symptoms until they become diagnosed after 5 years, or even for a lower patient after 2 years. So here there is a mandatory need for neuroendocrine multidisciplinary approach. Multidisciplinary approach includes a multidisciplinary team with expertise in imaging, pathology, and treatment. Multidisciplinary centers are associated with improved survival for patients with neuroendocrine tumors. Median survival of patients with metastatic neuroendocrine tumors treated at centers of excellency is more than 3 times higher than median survival of patients with neuroendocrine tumors in SEER database. Broader range of information and therapy from multidisciplinary approach patients. Access to a neuroendocrine tumor, MDT, improves the patient's perception of the quality of care they receive. Thank you for your attention, and I hope to see you very soon. Thank you. This is my last slide. Thank you.
Thank you, really, Professor Mohammed Yassin. It was an excellent talk, and you handled the subject perfectly. And I cannot imagine there would be any questions, and we don't have any time. But if you must ask, you can always send us your questions, and we will forward them to Professor Mohammed. And I really apologize. I said this was, thank you. I said this was the last session. We still have a remaining session that we're going to move on to now. So thank you very much, and I'm closing this session.